are you doing?
George Castles from
Hi,
New England Allergy.
Good to meet you.
We're trying to form a partnership with in countries for tele. With me, who owned the practice for about 45 years. About so we'd love to do something.
Ladies and gentlemen, if we could return to our seats, we're going to begin this afternoon's program. Ladies and gentlemen, if you could come in and take your seats. Is that it? People aren't.
You want me to keep it up here with you?
Yeah, I'm not losing. Ladies and gentlemen, if we could ask you to take your seats, we want to begin our next panel.
Yeah. Just so you know that I'm going to put the slide advancer. So someone wants to start the slide. Perfect. Thank you.
Hi, Doctor.
How are you?
Good to see you. Thank you. Ed
Great
Burton.
moderation.
Thank you. We're going to begin our next panel discussion. If we could take our seats, please, ladies and gentlemen. Our next session will be opportunities for collaboration in the Saudi healthcare industry. The moderator for this panel is Dr. Nisar Zain, Chairman, Global Patient Services, Mikati Foundation, Endowed Chair and Professor and Chief of Hepatology at the Cleveland Clinic. Doctor.
Thank you for the kind invitation to be here. It's an honor. I am in the company of 4 very distinguished panelists, which we will introduce in a minute. I am familiar with Saudi Arabia. I grew up in the Middle East. I have watched Saudi rise to prominence, both economically and to some degree in tertiary health care. It became the place to go when there are complex medical cases in the region. However, things are changing. We have Vision 2030. We have the NTP, the National Transformation Plan 2020. How would that impact Saudi health is part of what this panel is about. So our panel is going to discuss opportunities for investment in healthcare in Saudi Arabia. I am going to introduce my panel, and we will follow the same structure as we did earlier for the previous panel. We will give each of the four panelists about 5 to 10 minutes to present some thoughts, some reflections, and luckily that our panel is quite diverse in their experiences, both in Saudi and elsewhere. When we finish this presentation, we will open up the floor for discussion. I will ask my own questions if there is time, but I will invite and encourage participation of all those present today. So our panel, to my left is Dr. Fayyad Dandashi, who is Assistant Deputy in the Ministry of Health. To his left is Dr. Paul Rothman, the CEO of Johns Hopkins Medicine. To his left is Dr. Khalid Al-Shaybani, who is Deputy Minister of Health in Saudi Arabia. And last but not least is Mr. Dennis Kargat, who is CEO Emeritus of DaVita International, the well-known dialysis chain globally. With that introduction, I would like to open the floor to the panelists to give their 5 to 10 minutes reflections. Dr. Dandashi.
Thank you very much. Your Excellencies, ladies and gentlemen, it's my sincere honor and pleasure to be part of this unique conference, New Horizons and Opportunities in the Saudi Healthcare Sector. As the title implies, we have collectively chosen this title just to reflect the actual content of the event. I would like to start my speech by addressing the 2030 vision of Saudi Arabia. Saudi Arabia, a G20 nation with a GDP of $640 billion US. Our GDP per capita is around $54,000 US at a purchasing power parity. We had a GDP growth of 3.8 over the past 15 years. We are a 32 million nation. Our population is growing at 2.5%. And we are a youth nation whereby 50% of our citizens are below the age of 25. And as stated in the previous video, that we are 5 hours away from 1.5 billion consumer. The country of Saudi Arabia has embarked upon an ambitious vision, defined as our journey toward a sustainable economic structure and placing the kingdom at a prosperous path, with a scope on economy, public sector, and society, aiming for substantial economic diversification, localization, public sector efficiency, and wealth accumulation. Our vision is built upon 3 pillars, where we consider them the distinctive capabilities of Saudi Arabia. The heart of the Arab and Islamic world, the investment strength and powerhouse, and the hub connecting the 3 continents. Our vision is built again on 3 themes: a thriving economy, a vibrant society, and an ambitious nation. Most relevant to our discussion today in the thriving economy component is the private sector contribution to GDP. We believe that within our 2030 vision, the role of the private sector and their participation in the GDP will increase from current 40% level to 65%. We have a vibrant society. As stated earlier as well, the average age is around 74, and among other programs or other initiatives, strategic imperative initiatives related to vibrant society. There are enabling and executive programs that helps achieve our vision. Most relevant to our discussion today is the National Transformation Program and the Privatization Program. We believe that the private sector role in our National Transformation Program is to support, I can't read from here, but it's just to increase the participation on the National Transformation Program and contribute up to 40% of that spending. In addition, there is a massive contribution to the localization program, which is estimated and sized up to 270 billion Saudi riyal. The private sector is expected to play a bigger role on job creation, and we estimate that more than 450,000 jobs will be created by the private sector, among playing a vital role in digitization. Saudi Arabia is, by design, the largest healthcare market in the region. The market is estimated to be around $35 billion US. And we have been growing over the past 6 years at a CAGR of 14%. The structure or the landscape of the healthcare sector in Saudi Arabia is very much public and government dominant. Almost 75% of the services are provided by the government and 25% by the public sector. In addition to that, on ambulatory care level, around 45% of the centers are provided by the government and 55% by the private sector. However, we are heavily dependent on import. 70% of our medication in volume-based is imported, and more than 80% on value-based are imported. We are north of 90% import on medical devices that all create the need and indeed the urgency to start thinking of an ambitious localization program. Despite the historical expansionary budget and spending on infrastructure, still the government has not kept in pace with the rapid population growth over the past 10 years. Population grew by 40% from 2002 to 2012, whereby primary healthcare centers has grown by 25%, and still lagging behind the MOH target of 9.1 in terms of ratio per capita. We're still in the 7.7 per 1,000 population. Same is applicable for the hospitals and beds, whereby we are in the 2.1 per 1,000 population and still behind and lagging behind MOH target of 3.5. This is the most common and famous slides of our transformation, which will be tackled, I'm sure, by my colleague, Dr. Khalid al-Shibani. However, I would like to emphasize on the role of the private sector in our transformation program. The private sector participation will increase from current 25% level to 35% within the coming 5 years. The Saudi market is or has the fundamental drivers to continue its growth in the future due to a stronger demand driven by population growth, driven by the expected increase in the age population above age of 50, and is driven by the increased incidence in non-communicable diseases. We size up the market, and we believe that the spending is expected to be cumulative over the coming 5 years of $130 billion on service provision, 42 billion on pharmaceutical, and 11 billion on medical devices. That's excluding education and training. Currently, we have 40,000 beds at MOH, 17,000 beds in the private sector. The spending and the breakdown of the pharmaceutical and medical devices is showing clearly, 4.1, 2.3, and 1 on the pharmaceutical, and the same is applicable on the medical devices. So I believe with 35 billion budget a year, US dollar, per annum. Again, the estimated size of over the coming 5 years is around 180 billion US dollar. That's a sizable market. There are specific opportunities that we'd like to address. On the service provision, we're going to highlight it in a minute, and my colleague, Dr. Khalid, will discuss in details the 9 themes that we believe are attractive for the private sector participation. We believe that if the private sector would like to or want to match the government standard or government ratio in terms of number of beds, we still believe there are 10,000 beds capacity gap in our system, despite the pipeline increase in bed capacity. Most importantly is what we believe the pain point for Saudi Arabia, and what we call it or define it as DALI, disability adjusted lost years. We have high incidence of road traffic injuries, ischemic heart diseases, major depressive disorders and illnesses, and diabetes. These are the areas that we would like to focus upon. On the pharmaceutical, we believe there are opportunities within vaccines manufacturing, sterile injectables, plasma fractionation, generic medicine, biosimilars, APIs. On the medical devices, medical beds, imaging, monitoring devices, etc. Therefore, there are more than 35 concrete investment opportunities within the Saudi healthcare sector, let alone what we believe will be driven by the public privatization program or private sector participation program, which is totally different component rather than the actual unmet or latent demand in our system. What we are trying to do is to help enabling that investment ecosystem. An example, a complete revive on our regulation and bylaws. We're studying best in class bylaws and regulation, and we are very close on the process of releasing the most updated bylaws of the private healthcare system, whereby opening up the market for further and additional opportunities that are details down. So in a nutshell, Saudi Arabia is trying to underpin its investment climate to be more favorable. We are trying to increase the value proposition of the healthcare and the investment ecosystem in Saudi Arabia. We have some incentives, we have low tax burden, and a subsidized offers on lands that are related to manufacturing and localization. Thank you very much.
Dr. Rothman, I would like to hear about Johns Hopkins.
So good morning. I wanted to thank the organizers for asking me to speak today. I will say I've decided to never do PowerPoint presentations again, so you're going to have to focus on me. I apologize. My initial goal was to describe this partnership we've had with Saudi Aramco for 3 years now in the Johns Hopkins Aramco Healthcare. After this morning's talks, I've had the added goal of providing you as much dopamine as possible in the shortest time period as possible. So I'd like to tell you a little bit about our partnership with Aramco. And Saudi Aramco has provided health care for their employees, 360,000 employees and dependents in the kingdom for many years. They reached out to us to see if we could help them and provide them with a higher level of care and more focused on access and patient-oriented, patient-centered care for their employees and dependents. And it was very important for them as this disease burden we've talked about in terms of overweight, diabetes, and obesity affects the Aramco employees and their dependents as much as it does as in other people in the kingdom. And so the goal here was to set up a joint venture called Johns Hopkins Aramco Healthcare, in which jointly we would take care of these 360,000 employees and dependents in the kingdom. When we went in, we asked, where can Johns Hopkins really add value? Because Aramco already had an excellent healthcare system for their employees and dependents. And so we focused on 4 areas where we thought we could set up models that might set up a model that could be expanded to other places in the kingdom. And so there are really 4 areas of focus that I'll discuss today in the next 5 or 10 minutes. The first of them is to focus on what we do best at Hopkins. Most of you, I hope all of you know about Johns Hopkins. I won't give you the sale pitch, but in my opinion, and I am the CEO, it's the best healthcare system in the world, my humble opinion. And yeah, I know. And Peter Slavin is gone, so I can say that. So anyhow, and one of the things we really focus on is patient-centered care. We really believe that doing that makes us better providers, and I think the evidence suggests it provides better health care to patients. And again, we thought we've done a lot of things at our Hopkins hospitals to think of how you can do that. One, I think the more robust things is think of a care delivery team rather than just as providers. And that team is nurses and physicians, but also patients and their families, and to start to incorporate the patients and families in their own care. And that's something that we're doing now in JHA at Saudi Aramco. In addition, Hopkins does provide extremely innovative and novel care, and we thought that that was something, again, that could be added value to Aramco employees. And so we've done things like take Da Vinci robots and introduce them to the care of the patients there. At Hopkins Hospital, 90% of women who get hysterectomies do it by minimally invasive or robotic surgery. So we now have started to do robotic surgery at Aramco. And so that's a high-end tech, but there's also other things that we do that really helps patient care, like palliative care, which is not robust in the kingdom, was not robust at Aramco. We think is really important for patients. So we've introduced nursing and family-based palliative care for the employees and dependents in Aramco. Those are the sort of things we're thinking about. We've really focused on access. That is an issue that all providers have, given just the disease burden we're seeing. We've put in a lot of systems to get better access for patients, for their providers as soon as they can. And for us, when you look at patient satisfaction, it's always access that we really focus on, because it's really the major cause of patient dissatisfaction, at least at our system. So I think that collaborative patient-centered care is one thing we've been able to add to Aramco. The other thing that we've thought about is patient safety and quality. At Hopkins, it is our #1 goal to make sure that we provide the safest care and highest quality care to every patient that enters our door. We began down this road over 10 years ago with the founding of the Armstrong Institute for Quality and Safety. That institute around the world has initiated things like checklists in the ICUs to ensure that central lines are put in the safest way. And that's really changed American healthcare, and really now we've been able to export that to over 15 countries where we help manage or run hospitals. But in addition, we do things, one of the big things that we have been able to export that is sort of resonates with hospitals throughout the world is what we call comprehensive unit-based safety programs. What we found is that in a unit, nurses and doctors sort of know where there may be potential harm to patients. And so in these units, we have one at every unit at Johns Hopkins Hospital. Every month, nurses, doctors, staff get together with patients and ask, where's the next potential harm? Where's the patient going to be harmed? And every one of those units has an administrator like myself. I do the delivery floor at Hopkins Hospital. So I'm there to make sure that patients and their families get the best care, that we are accountable for that care, and that we ask every month, where's the next harm? Where's the next patient going to be harmed? We've now exported that to Aramco in their ICUs, and eventually on all the units at the Aramco hospitals are going to have these what we call CUSP units. Number 3 is population-based healthcare. Hopkins has had an insurance company for 20 years. We have proprietary IT that helps us identify high-risk patients and intervene early on. Again, the goal here is to bring down healthcare costs, get those people before they get ill. As we develop our IT systems at JHA, at Aramco Johns Hopkins Healthcare, we're going to export those same systems of identifying high-risk patients before they get sick. And it's really, again, what we talked about this morning is true. We have to get people, we have to take care of their health and wellness rather than just their illness. And the 4th area that we're very proud of is actually the growing demand for physicians, nurses, and allied health professionals in the kingdom. We really think that the kingdom needs to produce homegrown physicians. Obviously, they do a lot of them, but we think we can add a little bit of value there. Within our own health system at JHA, every department chair at Johns Hopkins Hospital has gone over or will go over there to do several days of training and education of the physicians at JHA. In addition, we have residents who are at JHA will come, and Aramco and Saudi will come visit us at Johns Hopkins Hospital. And one thing we're really proud of is with our School of Nursing, we developed the first doctorate of nursing practice. So, you know, in American healthcare, we know we don't have enough physicians to take care of all our patients' needs. So we have what we call mid-level providers, those physician assistants or nurse practitioners. Again, there was no training program in the kingdom for what are called nurse practitioners' doctorates. So we've set up that program. We've had 13 of our nurses go through it the first year to get a doctorate in nursing practice. We think that's going to lead to, first of all, them becoming trainers for the next generation of nurse practitioners who want to practice and think about changing healthcare from just a physician-led healthcare system to one that we have physicians, nurses, pharmacists all forming teams to take care of patients in the kingdom. So we're very proud of what we've been able to accomplish so far. We have a great partner in Saudi Aramco. We've been very careful to think about cultural competency among the patients there. We know that there are certain cultural things that we can export, but we're very conscious of ensuring that the patients that we treat in the kingdom get the same level of care that we provide patients in Baltimore, but also in a way that is culturally consistent with their values in the kingdom. So it's a great partnership. I know we're going to talk later, so thank you for inviting me again, and I appreciate everything you do.
Dr. Shabani?
Thank you very much, Dr. Nizar. Ladies and gentlemen, good morning to you all. It's really a pleasure to be here in this beautiful town, Boston, and amongst friends and hopefully future partners. I think I'll start my slide presentation. Unfortunately, I do have a PowerPoint presentation. It's really very exciting to be amidst this huge transformation that's taking place. It's not every day that one is part of a complete reform of the health sector that is going on now in Saudi Arabia. It's really unparalleled. And as my colleague Dr. Fayyad mentioned, this is an iconic example of or image of what the health transformation is about now. Over the last year, we've been working and planning on these 7 components of the transformation, at the centerpiece of which is the model of care. The country has gone a long way, and the Ministry of Health has gone a long way in the last few decades in building hospitals and primary care centers and in providing care for its population. This is a major shift in our thinking. We are moving away from building hospitals and buildings into more of clinical pathways on how to manage our health and how to keep well. I mean, commenting again on Dr. Fateh's comments, one of the components of the model of care is the prevention. And we put a large emphasis on the wellness and prevention, and its components related to it also in terms of supporting the primary care as never before. But also we've identified the blueprint, and this was launched last week in Riyadh, the blueprint for the model of care, tackling 6 main themes, one of which is palliative care, which is, again, end-of-life care is something that has not been addressed properly in the country. Other components of this reform are, of course, the governance, which again means here that the Ministry of Health is going to be a governor and a regulator. But also it will establish an arm's length entities and bodies that will regulate this new health ecosystem. Today we have the Saudi FDA, we have the Saudi Commission for Health Specialties, we have various regulators that exist today. However, in the new bodies will be created. The first Saudi Patient Safety Center has been launched already. A Center for Disease Control will be launched in the beginning of next year, and a National Institute of Health that will be dedicated to research in health is also being launched hopefully next year. Then, of course, the provision, moving the provision away from the Ministry of Health and more towards the initially holding companies that will be taking the opportunities and clustering some of the services that exist today in the ministry, primary care centers, centers of excellence, as well as hospitals and medical cities around population areas. So really it's delivering care on a populational health basis, similar to the accountable care model that exists today. The other components, of course, is what we're here for today, and that is the private sector participation. Of course, corporatization will eventually lead also to privatization, but also we intend to engage with the private sector wherever there are gaps in the service that exist today, very clear gaps in the service, or where we need really an infusion of efficiency and effectiveness in the midst of our operation. We know this reform takes time to implement, and the opportunities are large, but this is one of the areas that we are moving towards. Then, of course, the 2 main enablers, the workforce, and there is a huge undertaking now to, based on the model of care, plan a new workforce plan. And again, my colleague here mentioned about physician extenders, and in the new model of care, physicians will play a role, but there will be other new additional models or providers of care that are not going to be physicians. So we really need to modify our training and our education to fill in that gap. And eventually, of course, the ultimate enabler, which is the digital transformation. And the Ministry of Health has not been doing very well in terms of keeping up with the technology, but we think it's an area that we can actually leapfrog. So we started off in the privatization sector by looking at about 35 real opportunities to privatize in the Ministry of Health. And based on the criteria I mentioned earlier, we targeted specifically these 9 initiatives. And I will just briefly go through some of them to update you on as to what is going on. The general engagement is such that we first of all engage with putting the strategy for these initiatives. Then there will be an initial period of engaging with legal, financial, and business consultants to help us develop the model. And this has been actually, most of the projects we have engaged with our consultants to do that. And once we have the model, of course, today we have actually a model of care that is clinical care that is partnered with the private sector. In the dialysis project, we have now, this is our 4th year in the dialysis outsourcing project to a couple of companies actually. Dennis here is vice president for one of them, DeVita, and we're very proud about this initiative. However, there are learning lessons because this initiative was undertaken with exceptions and royal orders. So now we really want to put the legalities, the legal framework, so that it becomes a much clearer engagement. One of the other initiatives that are also out in will soon be out in the market are the imaging. Again, the intention here is to utilize technology and rather move away from being a buyer of equipment and managing them into really getting the final report and the final result. So again, the financial consultants are on board with the legal consultants, and we're working, actually we intend to pilot. The idea is really to pilot some of those projects, to test them on a limited scale, and then once the process is clear and identified, we can then scale up. So here, for instance, in the imaging, we're looking at King Fahad Medical City with a group of hospitals and centers that report to it, giving a comprehensive solution for the radiology. Today we have over 30 hospitals in the Ministry of Health that is over 80% built, and that we're most likely not going to commission and operate the old way. So again, we are piloting 2 of them, one in North Riyadh and one in Medina. Again, discovering what are the models that we really need to get them operational on. Most of those hospitals, frankly, have not had proper feasibility analysis and an assessment before they were built. So now we're redoing some of the feasibility assessment to know, and the business cases for them, to know where we're heading. If I read from here, sorry, I cannot. This is the primary care lab. Yes, again, the laboratory service is one of the areas that could be very easily outsourced, or we could find a good partner to deliver that. And the pilot that I'm describing here is actually related to Riyadh. We're piloting Riyadh, and we're taking out 180 primary care centers. And by the way, all of the 2,000 plus centers that we have, almost all have pharmacies, have laboratory services, and most of them have imaging services as well. So we're looking into that as well again. This is extended care. Under extended care, clearly this is a big gap in the service that we have today. Up to 30% of our hospital beds really are occupied by patients who can be treated either at home or in a rehab center or a long-term center. So we're piloting again an area, Iwa Hospital, which is a 400-bed hospital. This is in collaboration with our colleagues in the Ministry of Interior. And it's a good potential opportunity to outsource all these 3 activities. Lastly, the primary care centers, we made sure that we've requested a significant budget to upgrade and create new opportunities in our primary care. In specific, we're trying to develop, because we have lack of proper training, lack of number of family doctors, because we don't have really the facilities to train them, and we don't have the manpower to train them. So the idea is really here to develop up to 100 mega centers, or called urgent care centers here, that can work around the clock, that can utilize the human resources from bigger hospitals and medical cities who are not being utilized very well now, and create a good training programs to triple or quadruple, hopefully, the number of graduates from that will do family practice eventually. So again, here the model could be a build, operate, and transfer, which means basically building these 100 facilities, or facility management on the longer run, or a long-term contract even with the service provision, clinical service provision. Lastly, the pharmacy is a bit more complicated. Again, as I mentioned, we have no idea or no plans to maintain our pharmacy and supply chain practice. Today we have over 200 plus warehouses, and we really, as a Ministry of Health, we shouldn't be into the business of supply chain, specifically with the downside of it, if not really the technology is not enabled. We suffer great losses here, and also availability of medication at the right time to the patients. So again, every primary care center of those have a pharmacy and have a pharmacist. And that's, again, it's a big drain on our services. So the idea here is really we're looking at multiple factors. We're collaborating with the Saudi FDA and other agencies, hopefully with the idea that this will be completely outsourced. I think this is my last slide. Thank you very much.
Good afternoon. Dennis Kogad representing DaVita. And probably I do have a small presentation, so I'll go through it quickly. But I think the most important thing I want to say is someone who has been in the kingdom since 2012 in a very small joint venture, just testing the water of what it's like to do business in Saudi as an American company, and then bidding on and winning the first dialysis tender in 2013, which was the kingdom's first attempt to outsource and privatize. And as someone who has led DaVita into 13 countries over the last couple of years outside of the US and rejected twice as many of that for a variety of reasons as to why not to enter, I would simply say to you that if you're a healthcare services company with a high value-added product or services or drug, I can't think of a better place in the world to be than Saudi. That may sound like a real commercial, and I'm going to walk you through some of the growing pains over our 3.5-year journey with the Ministry of Health. But when I think about the needs across the world and the maturity of some markets and access and having a strong partner like the MOH and other people in the government, I've said this to our own board of directors, despite some of the challenges and the growing pains of learning to navigate what is a very tricky market compared to a lot of other markets outside the US, there really isn't a better place in healthcare right now. If you want to be part of the transformation and you have something that's going to aid in that, bring real innovation to Saudi, I just think it is a remarkable opportunity. So look forward to telling you about it. All right, DaVita. At the end of the day, kind of two aspects of DaVita just to ground you in our portfolio. For a very long time, we were a kidney care company, pretty large, second largest globally. In terms of the US market, 1 out of every 3 dialysis patients are treated in a DaVita dialysis center. A couple of years ago, we made the transition from fee-for-service dialysis, in other words, just providing a dialysis treatment 3 times a week, to starting to provide some real integrated kidney care services, recognizing the unique kind of complexities of a dialysis patient, all of the comorbid conditions that contributed to his or her being in dialysis and having end-stage renal disease. In 2012, we bought an organization called Healthcare Partners. They're one of the largest population health organizations in America. We use the phrase cradle to grave. We take global risk, full capitation on about 2 million patients in America today, everyone from a newborn baby to end-of-life care, and it's been a really exciting business. And why is that relevant? As you just heard Dr. Shivani talk about the opportunities that are forthcoming in the kingdom, so many of those play to an organization like ours, where we provided holistic care to large populations of people. So we're excited. This is our footprint in Saudi today. I won't spend more than a second on it, just to tell you one of the issues that we faced in Saudi, and one of the things that's been very high on the list of the Ministry of Health is how do you provide more care and more access to the rural parts of Saudi? So we're just entering that phase of our contract execution. I know there's a lot of intensity around it, appropriately so. The prevailing thought was everyone in Saudi should have access to outstanding care. And given the demographics and just the geography of the country, getting into some of these more rural areas, getting good healthcare workers, nurses, and doctors to go to those areas presents some challenges. But of course, along with that comes some opportunities, particularly in the areas of televideo, telemedicine, telehealth, et cetera. But this is our presence today. When we bid on this in 2013, it was under the watch of His Excellency Dr. Abdullah Al Rabi'a. We said we had 5 kind of objectives if we were going to win in Saudi. Number 1, we wanted to improve the quality of care for patients. Number 2, we wanted to achieve clinically differentiated results. We didn't want to just come in and tweak something. We wanted to make it noticeably different, tangibly different, and I'll share those results with you in a second. And number 3, we were excited, a little naive, but excited about developing more of this Saudi healthcare workforce. And that's probably been one of our largest challenges as I think about the last couple of years. There's not an abundance of great Saudi nurses, and I don't mean that great as they're bad nurses. There are just not a lot of people today that have chosen healthcare below the physician level in terms of a career in Saudi. So helping to educate, to brand healthcare as a really respectable profession and get more and more local Saudis into the business has been a challenge, but we're actually making some progress there. We wanted to build a long-term relationship with the Ministry of Health. There are a lot of our focus today, almost all of it is with the Ministry of Health. But as someone who's been in the kingdom now since 2012, you start to recognize there are other opportunities in Saudi. You know, each one of the ministry inevitably cares for large patient populations. But today, and I think appropriately, our focus has been on the MOH. And then last, knowing that we had more tools to bear than just the dialysis portion, which is what brought us to Saudi, we're very excited to see everything that's happening towards kind of Vision 2030, the model of care. As I talked about, a lot of the new programs very much lend itself to organizations that are pretty diverse in terms of their healthcare services portfolio. So 3.5 years later, how are we doing? It was a slow start. We totally underestimated how difficult it was to get things done in Saudi, things we take for granted in other markets. How do you get a permit to build something? How do you find a local construction company? How do you negotiate? You know, how do you get visas for a whole bunch of caregivers, given that workforce really didn't exist in Saudi for what we needed? But, you know, we just kept plugging away through all those challenges, as most companies will do, and at the end of the day, we have made some significant progress. So it was a slow start, but if you look at our trajectory, particularly over the last 12 to 18 months, it's exactly where we hoped it would be. It just took us about a year longer. So kind of lesson number 1, as you go back and you start building models in pro forma and you think about what you want to accomplish in Saudi, this is an area that's been a little more challenging than others. The good news, though, is companies like ours and Diaverum, our partner, if you will, our collaborator in Saudi, there are more and more people that have become accustomed to doing business in Saudi. We hosted a breakfast at the C3 Summit last week in Riyadh, and it was for U.S. companies that were thinking about investing in Saudi. And as someone who's deployed over $150 million of capital in Saudi in the last couple of years, we really wanted to say, hey, if you have questions, unlike when we entered Saudi and there were no other companies that actually privatized a former MOH function, more and more people are getting some good experience in Saudi, and I highly recommend you leverage those people. You develop the relationships, and they can cut your learning curve down in a very significant way. We had some payment issues, and some of you may have heard about that. There were a lot of things that weren't anticipated. As Dr. Shivani said, a lot of the first bid was based on exemptions and royal decree. The process between the MOH and the Ministry of Finance, which ultimately processes and pays the bills, wasn't intact. So for about a year, we struggled, and we owned part of that, a learning curve in terms of how do you prepare invoices, who do you deliver them to, what's the right methodology. But again, that's another example of things that are kind of behind us now. Now I'm happy to report that we get paid in a pretty routine fashion, and the receivables in Saudi don't look any different than they do in any other country that we're in today. We've got 20 plus clinics. We're growing at a much faster rate now that we've got all the learning curves behind us, treating over 2,000 patients, dialysis patients in Saudi. Unfortunately, as we're taking over some of the burden for the MOH, the growth rate of end-stage renal disease in Saudi is exceptionally high right now. I think they've had a net gain of 3,000 to 4,000 new dialysis patients since we started. And I think that's just indicative of some of the comorbid conditions that the Saudis face in terms of diabetes, lifestyle, obesity, et cetera. So we're trying to make some progress, and at some point, everyone's focus is going to have to shift to prevention and wellness, to building some great chronic kidney disease patients, so we slow down this flow of patients going from CKD and needing dialysis. Saudization was a big part of our contract. At the end of our first 5-year term, we were to have 35% of our workforce as Saudi locals, Saudi nationals. It's been a challenge, but right now we're achieving that goal. And again, a lot of it has to do with marketing and branding. You know, nursing is an admirable profession, working with nursing schools in Saudi, et cetera, just to continue to promote what a good thing it is to be a healthcare worker in Saudi. We're doing incredibly well in our clinical outcomes. We've had a 40% reduction based on some of the data we saw in mortality. At the end of the day, that's got to be the ultimate proxy. 100% of our patients are now registered for transplant. Why is that significant? If you're not on a transplant list, the odds of you getting a transplant are pretty much zero. Being on one doesn't guarantee you anything, but at least you have a fighting chance. There's some other statistics we're really proud of. Patient satisfaction, polling patients that were treated in an MOH clinic prior to DaVita and now treated in a DaVita clinic. The last patient satisfaction had us at about 93%. That's a really good mark, and we're really pleased and proud of the work that went into generating that kind of patient satisfaction. And I think as a result of the care that's being delivered in these new clinics, by reducing hospitalization, reducing catheters, improving vascular access, et cetera, from a total cost of care perspective, just intuitively, you know you're bringing those costs down with each of those initiatives. So back to my opening, why is Saudi important to us? We look at Saudi and we just say it's the hub of everything that happens in the Middle East. If you perform well in Saudi and you do well in Saudi, there are a lot of people in a lot of neighboring countries and emirates that are watching the Saudis saying, I'm just waiting to see how well this goes. Our ability as a company to now go into the neighboring communities of Saudi and point to the work we've done at the Ministry of Health has been a very significant factor from a business development perspective. So while we could have started in a much smaller market that had a couple of hundred or 1,000 dialysis patients, the bid came forward, and that's where we chose to plug in, but it's having a profound effect, kind of a domino effect, as more and more people outside of Saudi are talking to us. We talked about the prevalence of lifestyle diseases in Saudi. At some point, it's got to be addressed. Focus has to shift from treating illness, as our colleague from Johns Hopkins said, to prevention and wellness and education and mitigating all the high costly downstream things. There is a supply and demand and access issue in Saudi, but the MOH with their plans to privatize and to get out of the business of delivering healthcare and in the business of regulating, I think addresses this issue in an incredible way. And probably most important for me, over the last couple of years, there has been a remarkable transition to really feel like a partnership with the MOH. And I do credit my colleague, Dr. Shivani, for being a big transformative aspect in terms of the relationship. It has migrated from a contractual relationship where we won a tender to being a real partnership, where you can walk into the MOH and you can address your issues and things get done on both sides. So I give a lot of credit to the MOH. And I think at the end of the day, that's kind of our state of affairs in Saudi, and I'll go back to where we started, and I think about the universe, and I've led DaVita's international efforts since its inception. There are a lot of really exciting markets out there, but when I think about the opportunity to transform, make an impact, and have a strong partner that's embracing and engaging companies like ours, and I suspect many out there as well that have high value-added products and services, we are excited to be in Saudi. We look forward to participating in some of these other tenders. So if you're wondering, how's it work for us? To me, the end is we're going to double down. We're going to participate in some of these other tenders. We hope to become more relevant to the Saudi healthcare system. But I think at the end of the day, it really puts our money where our mouth is. We could just continue to do our dialysis bid, but no, we feel very strongly about this market, the opportunity to help. We applaud the efforts of improving the healthcare in Saudi led by the MOH. So it's the right time, the right place, and I suspect it is for many of you as well. So thank you very much.
So thank you all. Four panelists will kick off the discussion with, I'm going to use a quote of President Trump. a couple weeks ago who said, who thought healthcare is so difficult or so hard to navigate? So in that vein, I think it is when I think of transforming healthcare, you think of access, you think of quality, you think of cost, and it's very hard to imagine you can make big impact in the short term on all three of them. In fact, if you look at in the United States, the Obama care provided significant access, improved access, but costly access. And the reform bill now is talking about saving money, but the access will be even less. So where do any one of you, we have in this panel 2 individuals from US firm who did business in Saudi and 2 from the kingdom. Each one, any thoughts on where do you think the focus should be in the early stages now, in the coming year or 2, and which will drive what opportunities for foreign investors who want to invest in healthcare? We can start, if you want, all the way from the end, Mr. Kogat.
Mike's on. If I don't answer the specific question, you can come back and ask it again. But I actually think one of the ideas that's being teed up right now, really starting with primary care, as someone who is in the population health, taking global risk on several million patients, and I think our colleagues from Johns Hopkins will tell you the same, primary care doesn't really exist in Saudi today. Many times it is the emergency room, and emergency rooms aren't built or equipped to handle primary care. It places an unnecessary burden and cost on care, and patients that need good primary care don't get it, and patients that need good emergency room care are somewhat impeded by having crowded emergency rooms. So I think one of the places that the government has chosen to start with building a great primary care platform, moving from a volume-based healthcare system to value-based, which I think is the end state in Saudi, you can't leapfrog building a great primary care. And the doctors don't exist today. We've heard twice this morning about physician extenders and the need to create those, with the concept of 80% of your patient population relatively healthy and, doctors practicing at the top of their license, so the need for extenders is incredibly important. But the long-winded response is, I think primary care is going to go a long way to shifting the focus from treating symptoms and treating illness to prevention, wellness, and education. And I think if you get your arms around that, so many of the issues in Saudi just become managed over time.
Thank you. And please keep your comments short to give a few minutes to the audience for questions. Mr. Shaban.
I think basically we're dealing with 2 things. I mean, there's the urgent task at hand, and that is to reform our health bodies, and there we can find some areas of quick wins. But there is the very important path, which is along the prevention and the wellness. And that clearly, if we don't do anything about it, it will have a huge impact. It will not be sustainable. So I think this is the balance that we're looking at it. In terms of the immediate actions or quick wins or low-hanging fruits, I think again there are a huge amount of efficiency gains in the work of the ministry. Today, in terms of access to some of the ministry's activities, we've managed by establishing KPIs and sharing those along all the hospitals and making them available to see. We've established competition and an improvement of anywhere between 20 and 30%. So some of those are quick wins, really, but a reform of this size will need a long time. But you need to gain also the confidence of the people that you are moving in the right direction. And I think we do, definitely in the Ministry of Health, we do have few initiatives that tackle, that are short kind of quick wins, short and fast, and can add, using technology, for instance, again, using apps and devices to communicate with physicians, especially in remote areas. This will add a new flavor to the healthcare in the country, and will again inject a lot of enthusiasm and acceptance for the change, which is going to be huge.
I'm actually going to agree with both of my colleagues. First of all, I agree that focus on primary care gets you a long way to access. First of all, you access your primary care. You increase your access to specialists because you get people who are now specialists are seeing out of the specialist office back into primary care office. and you bring down healthcare costs because you take care of them before they get ill. The other thing, I actually think leveraging technology is a great, you can leapfrog a lot of other countries. My understanding is that the percentage of Saudis online are greater than any other country in the world. This is what has been quoted for me. And to be able to utilize technology and leapfrog what a lot of other countries are using to provide healthcare, I think is a great opportunity for Saudi to
Thank you. Dr. Dandashi?
Thank you. If I may add, within the current healthcare landscape in Saudi Arabia, and I would say the value chain, the Saudi healthcare system is built on the classical mortar and brick model, where we have the clinics, primary care, and the hospitals. However, within that value chain, as early as prevention and as late as population health management, there are still, I would say, quality and quantity gap within our system, especially urgent care, post-acute care, long-term rehab. Those all, I believe, are all areas of untapped demand at the moment.
Thank you. There are Hani, I think I see you from here. Yeah. And then next, the gentleman next. Yeah.
Hani Najma, practicing cardiac surgeon at the Cleveland Clinic. Obviously, Saudi practiced there and just came a year ago. I have really been impressed with all the talks that have been delivered this morning. These are really high-level talks, which speaks really from top down. And I could see transformation in Saudi Arabia has to come from bottom up, because if you put all these lows from top down, at the end of the day, it's the execution of these strategies that you put in. And the execution is going to be incumbent on the practitioner, the health practitioners. And none of these talks have actually addressed this. We never talked about productivity of the physicians or health practitioners. Since I've moved from Saudi Arabia last year to the United States, this is what I found a major difference, is that work ethics, and we have to be transparent about that, productivity of the individuals. So we could plan and strategize as much as we can. If we're not tackling the actual delivery of these strategies at the lower level, it's going to be really difficult to come out with a tangible difference on the outcome. And that's going to obviously be wasted efforts. So I think it's really important these strategies have to include development on change of work ethics and productivity at the physician's level. I don't know what the panelist thinks about that.
Thank you. Very well stated. Any comments on the comment? Yes.
It was well stated. I totally agree. I think it's incumbent upon the ministry to get buy-in from the lowest level and kind of work back up. And you're right, so much of our success in other markets is based on productivity of everyone in the clinic, everyone in the center. And I think that's a relatively new concept that has to be incorporated. Otherwise, it's a really great design and the execution fails. So you raise some very valid points.
Yeah, I will thank you. I think I'll address then the first part of the question, and I think you're spot on. I think the model of care, which I emphasized on in the small short presentation I made, is actually pivotal, and this is why we did not cut and paste. There are existing beautiful models of care in the developed nations. We did not cut and paste. We went ahead and created, through a chain of workshops and meetings, invited a huge number of healthcare workers, in their hundreds, healthcare workers in government sector, in the private sector, patients. We've created an electronic platform that was contributed to by more than 3,000 people, again, healthcare workers, to design the future model of care. And based on this design, the implementation will take place. And of course, hopefully they will champion. There are identified champions now for all the blueprint that was made for the model of care. So I think here, and I fully agree, many times the clinicians, the front workers, the front staff workers are the ones that know the solution rather than the top. So this is the most central piece of our transformation, and it's been really designed by the healthcare workers and patients.
Thank you. I'm given the sign that we really have to stop. I just want to close with one word, that is, it's very clear to all of us that there is the determination and the vision to transform healthcare in Saudi Arabia. And when there is a determination and a vision, you will likely succeed. So thank you very much for the opportunity.
Ladies and gentlemen, a note on lunch. Given our large numbers of attendees, we've arranged 2 luncheon spaces, one in the Palm Garden, the other in the Commonwealth Ballrooms. Those are both located on the 2nd floor, the same level as the registration. If you're not assigned a seat in those tables, there are other restaurants and other food that's going to be available throughout this area. So please enjoy your networking lunch and be back here at 1:40, 40 minutes past 1.